Well, good evening, everybody. It is 7 p.m., so we're going to get started. Can everybody hear me?
Yes.
And you can see my screen.
Correct.
All right, so briefly, before we get started, we do have some special guests with us tonight to take us through our main topic, but we are going to do a quick COVID-19 update. We've decided that when we have these calls, we're going to kind of just do a brief overview just so everybody's aware of what's going on that side of things. As of right now, we are also going to be having these meetings, these webinars, the last Thursday of each month. Now, I'm going to throw a curveball at you right away. If you look at your calendar, the last Thursday of November is Thanksgiving. So we will not be meeting on that Thursday. We will either be meeting the week before or the week after. I think probably the week after, and then we might not have a late December meeting. So stay tuned for that. If you have not already taken the Northeast South Dakota AHEC webpage and made it a favorite, go ahead and do that. That is where there's a path to get onto these webinars on there as well. And that is where Michaela has our previous webinars as well. So if you have not made that webpage a favorite of yours, go ahead and do so. I'm betting somebody's just asking me what that website is, maybe in the chat. So Michaela will probably drop that in the chat box. We still will send emails out. The email list that I have is maybe a little bit dated due to the fact that it was made back in March when we started doing our COVID calls. So if you have updates to that, go ahead and email me. Let me know who we should get on there. We are obviously trying to grow this across the state. We have a lot of new people on tonight, which is really exciting. So welcome to you guys. I did get some different emails, and then we also had a plug for this put in at the conference last weekend. A little bit on the EMS conference for those of you that attended it. I'm sure you enjoyed it. You can still sign up for the conference. That might sound really weird because the conference was last weekend. You can still sign up for it and still get the 20 hours of training through the on-demand version where you can watch the lectures that have been recorded and you will be able to get that training. So if you so choose to do that, you can go to the South Dakota EMS Association website, which if you go on to the Northeast South Dakota AHEC webpage, there's a link there and you will be able to sign up for that and get that training. So it's another avenue to get training. Am I missing anything, Michaela?
Nope, I think that's good.
Okay, so we'll go through a quick COVID-19 update and then we'll turn it over to a physician from Sanford who's going to talk to us a little bit about a little bit about trauma and some different trauma scenarios. And I think, Michaela, before you start working on it with 24, I think we'll just stay in the big group, maybe. Does that sound okay?
Yeah, that works.
Okay. We are going to have some scenarios that we will work through as a group. So be ready to throw some input out there. One other quick thing. I did send in for ALS hours for these today. So probably starting in December, those of you who are advanced EMTs or paramedics will be able to get ALS hours for this. I'm also working on an avenue for those that aren't unable to be on the call tonight. I know we have some playoff football games across the state. So also looking for an avenue to get credit for those of you that watch this at a later date. So stay tuned for that. We'll get that out there. And if you have not signed up on the EMS portal, I know I have had one text already tonight, and that's totally fine. If you are not able to sign up on the EMS portal and you are a South Dakota EMR or EMT, please send me an email or send me a text at 605-216-4644. 1677 and let me know your name as it appears on your EMS card or your EMS certificate, and I will get you signed up for that after the meeting tonight. So without further ado, I'm going to get going. We will hold a question and answer session afterwards, probably, I'm thinking, and we will get through this in an hour so we don't take all of your evening. Although the World Series is over, so I don't know what anybody does at night anymore because I don't have anything to do. So I'm not sure what you guys are all doing. All right, so by the numbers, as of today, 10/29/2020, there are 918 new confirmed cases today, 82 new probables, which brings the active case total to 12,462. In South Dakota, recovered 30,000 plus. Currently hospitalized is 413. Again, obviously, everybody's kind of watching that number and hoping that our healthcare systems continue to do a fantastic job like they've been doing over the last 7 months in helping those people who have to be hospitalized out. So that number's obviously been ticking up and everybody's been watching that. Some county by county type stuff, some area counties. I don't want to leave out anybody who's not from the northeast area up here, but I just kind of grabbed some of our local counties. Brown County's at 388 active with 5 deaths reported. The 5th one was reported today. Spink is at 90 active, 1 death. Falk 79 and 1. Day County 38 and 2. Edmonds 31 and 1. McPherson 19 and 0. Marshall 14 and 1. So as you can see, since a couple weeks ago when we did kind of a trial run meeting, those numbers have increased. So protect yourself. Don't forget to do that. Wear the face coverings when physical distancing can't be established, whether you're on a call or you're not on a call. It's really been pushed through our healthcare systems, the South Dakota Medical Association. Those groups have really been pushing that, as has being pushed at the national level. So protect yourselves. Wear the appropriate PPE when you're responding to all calls. Don't get complacent. As these numbers start ticking up, you might have outbreaks in your community that you don't know about. So make sure you are wearing the appropriate PPE. Clean your rigs thoroughly. If you're not feeling well or you are a close contact, don't respond on calls, but also follow your agency's protocols there. I mean, make sure you know what those protocols are. Wash your hands, wash your hands, wash your hands, and then follow those local protocols. Cases are on the rise, obviously, unless you've been living under a rock the last month. You've noticed this. They've risen sharply in October. If you go way back to the very beginning of this, there was a model out there that kind of showed this. I don't know if it was specifically going to be at this level, but you know, whether this is our first wave or our second wave or our 7th wave or whatever, the if you drill right down to it, cases are on the rise, which in turn our COVID transports are up. So those of you that are running calls, if you're an active EMT or EMR or paramedic in this state, the COVID transports are up. You probably know that, which you have to make sure that you keep yourself safe, you keep your guard up, you do everything that you're supposed to do when you're transporting those patients, and we don't get complacent because, as you all know, probably way better than I do, is if we take one ambulance crew out of a small rural community, that cripples the EMS system in that community. So make sure you are keeping yourself, your crew, and your community safe. Now, another little short plug out there is if you guys are running into a shortage of EMTs, EMRs, and ambulance staff, don't hesitate to reach out to myself or Michaela at AHEC. She'll pass the word along, and we will get in touch with folks that can potentially help you out. So you're not alone. And if you are running into situations where you have crews quarantined or crews that have COVID themselves, don't hesitate to reach out, and we can assist you in getting you lined in with maybe the right people and some relief. So don't hesitate to ask. So with that, I'm going to stop sharing here, and I'm going to turn it over to Dr. Grabiel. Did I say that correct?
Yeah, can you hear me okay?
We sure can. Thank you very much for joining us, and the floor is yours, sir.
All right, it's nice to meet you guys. I'm new to the Sanford, actually new to South Dakota ever since August of this year. I came from Bakersfield, California. Initially, I did my undergrad at UC Davis in California before going to West Virginia for medical school, and that's when I really discovered I wanted to stay out of California. Although I did go back to Bakersfield for my emergency medicine residency, as it was a really good facility for training. It's a level 2 trauma center. We saw plenty of trauma, and I'm excited for the topic today. Let me get to my presentation here. All right, are you guys seeing my slides?
Yep.
Okay. All right. So I was going to discuss some topics on hemorrhage and trauma and relating to shock, how it is for y'all out in the field, and then as well as how that sometimes affects us when we receive the patient from you guys. So here's some topics to cover: circulatory system and blood, shock, hemorrhage, approach to hemorrhage control, tourniquet and some details about tourniquet use, and then a few extra considerations. It's kind of one of those things where it's always good to see other providers' perspectives. And so I could share with you just sort of how it is for me once I receive the patient. So a review of the circulatory system, just a broad overview. Adults have approximately 5 liters of blood throughout their system that they pump through their system about once every minute. It supplies nutrients and oxygen and removes waste, as well as a multitude of other things. It's made up of a network of branching tubes that can dilate and contract to adjust blood volume. There's 2 major divisions in the system that we think about. The systemic division, sorry, I'm losing my voice. The systemic division, which is really from the heart that pumps the blood through the aorta into the systemic arteries before going to the arterioles, before making its way to the capillary bed, where the majority of oxygen exchange as well as nutrient exchange occurs. Then it makes its way out through the venules, which are basically the tiny veins, going to the larger veins into the vena cava, superior and inferior vena cava, before making it back to the heart. That's in general a higher pressure system than the second division, which is the pulmonary division. And in large, that division goes from the heart through the pulmonary artery before making it to the lungs, and then back to the heart via the pulmonary veins. So there's some nomenclature differences there. If you notice, the oxygenated blood going to the system is going through an arterial system, and on the pulmonary division side, the oxygenated blood is going to be the pulmonary veins going back to the heart. Basically, the big vessels are named for whether or not it's going towards or away from the heart, not so much if it's oxygenated or not. Regarding blood, it's thought of in 3 major components: plasma, white blood cells, and platelets, as well as red blood cells. The plasma makes up the majority of it. The white blood cells and platelets make up approximately 1%, and the RBCs make up about 45%. There's an essential component to the blood that we don't always think about or consider, but we need to, which is all the clotting factors that play a huge role when it comes to trauma, when it comes from once the patient first has a traumatic insult through your care all the way to our care, all the way to the operating room. It makes a big difference how we treat that, and I think it's rather underemphasized sometimes. So shock is defined as a state of cellular and tissue hypoxia due to either reduced oxygen delivery, increased oxygen consumption, inadequate oxygen utilization, or a combination of these processes. Effects of shock, they're initially reversible if we intervene early, but rapidly become irreversible, resulting in multi-organ failure and death. Some common features that'll be prominent will be tachycardia. As it advances, a lot of times we'll see the hypotension. That'll be a little bit later. The tachycardia initially comes out sooner in hemorrhagic shock. The patient will become altered. And I know that it doesn't really apply to out in the field as much, but they'll end up having decreasing urine output. There's several types of shock, and there's actually several different ways of categorizing shock. One major way is as follows on this slide, which is divided into hypovolemic shock, cardiogenic shock, obstructive shock, and distributive. The hypovolemic shock is basically further divided into hemorrhagic versus non-hemorrhagic. For today's talk, we're more relating to the hemorrhagic. The non-hemorrhagic would be relating more to severe dehydration. Plenty of patients that you all see, but it's just not about the topic today. So just to briefly go over those, the non-hemorrhagic hypovolemic shock would be things like severe dehydration, burns, and GI losses, especially in children with the GI losses. They get these viral gastroenteritis with vomiting and diarrhea that's poorly controlled, and they get larger losses than we realize. With the cardiogenic shock, that could be secondary to a heart attack, cardiomyopathy, congestive heart failure, even things like overdose. When I'm talking about overdose in the setting of cardiogenic shock, I'm talking sometimes even like a beta blocker overdose, where the heart rate cannot increase according to the needs of the body. So they functionally are in a cardiogenic shock at that time. Obstructive shock, when it pertains to trauma, might be related to a cardiac tamponade. That could be from a penetrating or blunt trauma, but likely penetrating trauma to the chest that will cause fluid around the heart within the pericardium that causes a tamponade. And there's also the hemothorax in this setting where it's obstructive shock. It's actually a tension pneumothorax, that we'd be referring to. That's the one where the pressure is large enough to decrease the venous return to the heart. But there's other forms such as pulmonary embolism. That's another example. Distributive shock, that'll be talking about sepsis, anaphylaxis, or neurogenic. So regarding hemorrhagic hypovolemic shock, there's two large categories. You could think of external bleeding or internal bleeding. The external bleeding can be obvious or not so obvious. It's in large more obvious than the internal bleeding, such as the illustration here from Monty Python. The internal bleeding can be in the abdominal cavity, the thoracic cavity. If there's a pelvic fracture, especially an open book pelvic fracture, there's plenty of room for a lot of blood to pool. And that's not in the vessels, and that's not helping the patient perfuse and oxygenate. Also, sometimes there's a hemorrhage retroperitoneal, which won't be so obvious either. It's kind of behind everything. So once the patient comes to us and we're doing a fast examination or eat fast according to the ATLS guidelines, we can have a negative fast examination with the ultrasound and not see any blood in there. And that's when we've got to consider it being in the retroperitoneal. ATLS classifies hemorrhagic shock into 4 classes with increasing severity. It becomes more obvious. So the way they've divided it up for a long time, although there's a lot of crossover and this is not perfect, patients for multiple reasons won't go through these classes in order, and that could be secondary to medications that they're on. So if they're on beta blockers or calcium channel blockers, you won't see the tachycardia as early in shock as you otherwise would. But to talk about class 1 shock, this is referring to approximately up to 15% of their total blood loss, total blood being lost. And that's usually around 750 cc's. when someone presents this way, a lot of times they might not be tachycardic, even if they're not on a beta blocker or other medications such as digoxin. Their blood pressure can still be normal. Their pulse pressure is not decreased. Their respiratory rate may be normal, and their urine output would be normal. One of the clues for them is first that you visibly are seeing it, if it's external loss. Also, they can appear slightly anxious, is another clue. When you get into class 2, you're getting from anywhere from 750 cc's to 1.5 liters. That's about 15 to 30%. This is where you start, they emphasize more the tachycardia. And it's always a mixed picture because a lot of trauma patients, out here in South Dakota, it'll usually be trauma and volume loss and pain that'll be causing increased heart rate. But in some of those bigger trauma centers in bigger cities, it's a mixed picture with individuals having more drugs on board and things like that. So again, this is far from perfect. A lot of factors make patients not present like this. But if you notice in that class 2, the blood pressure is not decreased at this point. Although the pulse pressure is decreased. So remember that pulse pressure is the difference between systolic and diastolic blood pressure. So as you're doing your serial vital signs, you might notice that narrowing of the systolic and diastolic blood pressure. It's more of a subtle hint. The respiratory rate ends up increasing, and their urine output is going to be decreasing. At this point, they are still appearing somewhat anxious, but they're not so much confused. In the class 3, you start getting to about 1.5 liters to 2 liters of blood loss. The heart rate will be around 120 or higher. This is when you'll start seeing the blood pressure decrease. The pulse pressure will continue to decrease. Their urine output will significantly decrease, and the respiratory rate will increase. These patients will range anywhere from appearing anxious to start being confused. Class 4 is obviously the most ominous. It's around 2 liters of fluid loss, of blood loss. Their heart rate will be around or higher than 140, and their blood pressure will continue to fall. They'll have almost no urine output or no output, and they'll be very lethargic. Sometimes when we receive patients in this class 4, they go from looking real anxious and confused to confused, lethargic, and even sometimes this is the stage where they'll kind of, it's very interesting. It's kind of weird, but there's been, some patients will look at you and pretty much tell you they're going to die at that point. It's almost like the anxiousness goes out of them, and it's almost as if they accept what's going on there. Contributing factors that we need to keep in mind for these patients that might be the reason why what appears to be a capillary bleed or a venous bleed, why we're having a difficult in achieving hemostasis. This will be if they have a past medical history of hemophilia, liver disease. Liver disease, that'll often happen because the coagulation factors in the body, many of them are produced by the liver. When the liver stops producing those, then individuals don't clot the way that they should. Von Willebrand's disease, and any pathology that'll give you low platelets, as low platelets come together and create that plug to help initially with hemostasis. Medications, which is always so useful to have if we have a list of that and not have to ask the patient, especially when they're altered. A lot of times the first thing that we'll ask is, are they on warfarin, Xarelto? Are they taking aspirin or Plavix? If someone's on 81 milligrams of aspirin or even higher than that, it's not nearly as concerning as if they're on Plavix or warfarin or Xarelto. What's nice about warfarin is that there are things we can give to them to reverse. We can give that immediately. We can give them vitamin K as well as FFP and CCP. When it comes to Xarelto or some of those other medications, especially in rural medicine, we don't have the reversal agents as readily available. When it comes to external bleeding, There's 3 different main categories you can think of it. One is arterial. With arterial bleeding, you'll see more spurting of the blood. It could be pulsatile along with the heartbeat, and it's usually bright red in color. Venous bleeding will be more of a steady, slow flow, or dark, and is more dark red in color. The capillaries will be slow and even flow. One thing about the venous bleeding is that sometimes when you first start manipulating the wound, there might be some pressure that has built up in that wound. And so when you start manipulating it, it might squirt out a few times that makes you think, is this arterial? Obviously, you're going to be putting direct pressure and watching the wound longer. And so at one point you'll figure out that it's likely venous and it just had built up pressure as opposed to being arterial. So when approaching a patient in the traumatic setting, we often use the ABCDE mnemonic for our assessment. A is referring to airway. Whenever in trauma, whenever we're assessing the airway, we always have to keep in mind the C-spine stabilization. So we don't further cause damage to the patient. B is for breathing and ventilation. C is circulation and control of bleeding. Disability is their mental status. That includes, how responsive are they to you, as well as the GCS, which I know we use GCS in medical emergencies as well, but GCS, just keep in mind, GCS was originally created for trauma, and the majority of literature and patient outcomes with serial GCS scores is based off of trauma patients, not medical patients. The E is for environmental and exposure of the patient. One thing to keep in mind here is that we harp on the ABCDE as it's easy to remember, but if a patient is clearly bleeding and if the mechanism is all about bleeding, they don't really have so much head trauma, they're speaking to you and it's obvious. A lot of times we'll jump, instead of doing A and B, we'll put our attention on C first and then sort of go through the rest of our algorithm. Sometimes you can feel quite silly going through A and B and taking some time there when it's obvious that someone's bleeding from a large vessel somewhere else. Regarding some patient care, again, just further evaluating this traumatic patient, you want to maintain the ABCs and spinal precautions when indicated. That when indicated is referring to the spinal precautions. The ABCs, you'll have to reassess those as the patient improves or declines. If indicated, provide some supplemental oxygen. This could be important as bleeding and hemostasis is best achieved if the patient is not acidotic, and if they have normal oxygen saturation, and if they're not hypothermic. So basically, you just want to create the best environment for the body to function to stop the bleeding. If respiratory efforts are inadequate, you can assist with bag mask ventilation and consider airway adjuncts. You want to avoid the hypothermia, so remove all the wet clothing, cover patient to prevent further heat loss, and turn heat up in the ambulance if possible. If the pelvis is unstable and the patient is hypotensive, place a pelvic binder or sheet for stabilization. Again, you want to perform serial vital signs and neurologic status assessments. This will just keep reevaluating where the patient is on the classes of hemorrhagic shock. Of note, in the setting of major hemorrhage, hemodynamic instability, penetrating torso trauma, or signs of penetrating brain injury, minimize scene time. The goal is under 10 minutes. So by the time that the patient makes it to us in the emergency department, we're always thinking about and harping on the golden hour. The golden hour, if we're able to, from time of injury, the patient to the OR, if we're able to get them in there to the OR within an hour, their mortality chances significantly decrease compared to if there's longer times. There's things we can't help, such as extrication time and things like that, scene safety, as far as minimizing the scene time. Do not jeopardize scene safety. You have to take care of yourself if you're going to take care of the patient. Regarding extremity trauma and external hemorrhage management, there's some broad goals. You want to minimize the blood loss, avoid hemorrhagic shock. Those kind of obviously go together, but I think what's important here is that early minimizing the blood loss will avoid hemorrhagic shock. And so you really want to intervene while everything is reversible and the injury is not irreversible. You want to minimize pain and further injury as a result of potential fractures and dislocations. Part of the assessment is evaluate for obvious deformities, shortening, rotation, or instability of the extremity. Check neurologic status of the extremity, such as touch, and are they moving their fingers, moving their toes. Check vascular status of the extremity. Keep an eye out for, do you notice any pallor? Do you notice a pulse? Is it thready? Is it bounding? Is the capillary refill normal or is it delayed? And the degree of bleeding and the source. So when you're first looking at the patient, is it obvious that it's coming from an artery and you're going to maybe go towards using a tourniquet sooner, or is it something that's small capillary and potentially pressure? You can give a longer trial of direct pressure. So manage the bleeding. Apply direct pressure followed by a pressure dressing. If the direct pressure is ineffective or impractical, and if the injury would allow for a tourniquet to be beneficial, then apply a tourniquet. When placing a tourniquet, place it approximately 2 to 3 inches proximal to the wound. Do not apply over a joint, as it won't be as effective. Tighten until the bleeding stops and distal pulse is eliminated. If bleeding continues, consider a second tourniquet proximal to the first one placed. A lot of times for thigh injuries, you may need to have that second tourniquet as it's harder to achieve hemostasis with just one. You want to stabilize fractures and dislocations. If the distal vascular function is compromised, gently attempting to restore normal anatomical position may help with the vascular flow and perfusion to that extremity, and that can be very important, especially with these long extrication times, or if you're transporting for 45 minutes, that makes a big difference for the patient and salvageability of the extremity. You want to use a splint as appropriate. Elevate the extremity when possible to about the level of the heart or possibly a little higher. Apply ice or cold packs to limit swelling depending on the scenario, if it was a dislocation, relocation, anything like that. But do not apply the ice directly on the skin. And keep in mind that although you're trying to cool down the area of injury, overall you want to warm the patient and you want to keep them from being hypothermic. I can't stress enough how big of a difference it makes. If the patient is hypothermic and we're trying to stop bleeding, what that does to the coagulation cascade, it makes a big difference. And especially us in emergency medicine, we're kind of hypocritical on that, because I think everyone can notice that every trauma bay is absolutely freezing when you get in there. You want to reassess distal neurovascular status after manipulation or splinting as well. Anytime that you're manipulating it, if there's any question, reevaluate the neurovascular status. Patient safety considerations when using a tourniquet. Ensure that it is sufficiently tight to occlude distal pulse to avoid compartment syndrome. Ensure it is well marked and visible. Ensure all subsequent providers are aware of the presence of the tourniquet. So if you're working with a colleague, you're obviously talking about, hey, I'm applying the tourniquet. But then when you're handing off the patient, very important that it's visible and that everyone knows the tourniquet's on there, what time the tourniquet was applied. Again, so that we avoid going from helping the patient and possibly saving their life to unnecessarily losing a limb. I've actually had a patient myself that came in. This wasn't from EMS. This was actually coming from an outside clinic. The patient had gotten blood drawn the day before, and they applied a tourniquet just to do their butterfly stick for blood draw. The patient came into me 24 hours later with the tourniquet still on their arm. Their arm just looked horrible. But anything can happen. Perform frequent rechecks to determine if bleeding has restarted, and do not remove the tourniquet or dressing in order to reassess bleeding. Just try to reassess if the bleeding has restarted by just evaluating, but do not remove to evaluate if it restarted, because the clot that's been developed can then be flushed away and you have to start from zero again. Key considerations: tourniquet should not be removed if, this is coming off of some of the state guidelines there, if the transport time is short, so less than 30 minutes, if it's on an extremity with an amputation or near amputation, if it's unstable or complex multiple trauma patient, if it's unstable clinical or tactical situation. If the tourniquet is replaced with a pressure dressing, if there's the scenario where you can do that, do the best you can to leave the loose tourniquet in place so that if the bleeding returns, you can just quickly retighten it. Especially when we can't get blood products in the field, this is very important to keep all of their blood. Survival is markedly improved when a tourniquet is placed before shock ensues. And keep in mind the commercial tourniquets are preferred over improvised tourniquets. When applying direct pressure, apply firm pressure using gloves and gauze. Apply until bleeding is controlled. This may take several minutes. Resist the temptation to just keep checking. Keep the pressure on there for the amount of time you believe it will take to stop the bleeding. Do not recheck too frequently. If gauze becomes saturated, apply a new gauze on top of the old gauze. Do not remove bandages, and assess the pulse after dressings are applied. Again, this is just avoiding causing harm when our intention is just to help. A few considerations that are pretty big. Whatever the medications are that the patient is on that could be convoluting the picture, we want to keep this in mind. So you want to ask yourself, what medications is the patient taking and how does this affect the patient's clinical presentation? If you go to a patient who has a large laceration to an extremity, there's pulsatile flow. The call initially was 15 minutes. Somehow 15 minutes prior to you were able to get to the patient. I mean, the patient's can be pretty sick at that point. But if their heart rate does not match that clinical picture and they're, let's say, a little bit more elderly or someone who's got a history of blood pressure, there's a chance there's something such as beta blockers, calcium channel blockers, or digoxin that might be stopping that patient from advancing through the stages of, or the classes of hemorrhagic shock. So you have to keep that in mind. Also, thinking about the blood thinners they're on, such as warfarin or anything like that, it might explain why what seems like a minor capillary ooze or venous ooze, why we're having a difficult time achieving hemostasis, and that could be because they're on blood thinners. So just do your best just to do that, and then potentially if once enough history is obtained, then we can reverse it when they get to the hospital. Fluid resuscitation, this one's pretty big. So I don't know that it so much applies here, but oftentimes throughout the country, a lot of times crystalloids will be started in the field to help with blood pressure as a patient is losing fluid and we want to replace fluid. Something that's underemphasized, but now in the ATLS 10th edition, as opposed to the 9th edition, the 10th edition just came out recently, and it emphasizes more blood products early and less crystalloid. Those crystalloids can make us feel better about the blood pressure, but where we have to be very cautious is we're diluting the coagulation factors, and we're going to have a harder time stopping the bleeding. Thinking about crystalloids to keep to achieve a systolic blood pressure of 90 or above might be a great goal, while keeping in mind permissive hypotension. So let's say a patient tells you my blood pressure is always 160. Our goal would not be let's get them back up to 160. It would be to keep them from being too hypotensive, but we don't want to increase their pressure so much that we blow out the clots that have helped us keep the patient alive in the meantime. When applying direct pressure, do the best you can to use your fingers. We use gauze and we use our hand and we apply to the wound. But if you're having a hard time achieving hemostasis, check to make sure you're not using too much of your palm and you're not doing more directed pressure with your fingers. It can make a big difference as well. If you're checking for stability of the pelvis, do so and have everyone know, whichever clinical setting you're in, that you're checking the pelvis. And once the pelvis is checked, if you feel, try to just do one solid effort to check the pelvis. If we keep rocking the pelvis or moving, those blood vessels that are coming through the pelvis that have been sheared through the fractures that occurred during the trauma, we're going to keep, first of all, removing blood clots, but also injuring more vasculature going through the area. When possible, communicating to receiving facility that the patient is on their way. Now, this isn't obvious, and when I'm stating this, I'm referring more to when you keeping a tighter timeline with the receiving facility. I think this is all of us just trying to consider what the other part of the team is going through. That during emergency medicine residency, we spend a full month, which should be longer to be honest, working with you guys in the field to try to understand what you're going through. And it really helps us to understand why or in what ways or what's important to you in your prioritizations when you bring the patient to us. Well, one thing that's easy to say on our side is, why don't you give us a bigger heads up for this patient coming? And I think that just has to do with communication, working as a team. We have to understand that you guys are having to consider many things. That you're taking repeat vital signs, you're considering other patients in mass casualty, all those things. So we need to remember that's what you're going through, and when and if possible, recommunicating any alteration in time so that we can take care of our patients that we have, but at the same time, be ready for the patient for their needs, whether it's blood products or a pelvic binder on the gurney, so that we can all move the patient onto a set, ready to go pelvic binder, rather than having to roll the patient, do more shearing force on vessels and cause more bleeding and things like that. And here are some sources that I had.
All right, thank you very much, Doctor. Does anybody have any questions for Dr. Grabiel? Sorry, I'm butchering your name.
Oh, no, that's okay.
Anybody have any questions? Nothing showed up in the chat box. I guess one question that I had, and you kind of touched on a little bit, was the heads up time. So you were talking about potentially having to place that second tourniquet. Is that something that you would rather be called upon, right away after it's done, so you're aware that there's a second tourniquet placed? Or I guess maybe the overall question is, when an EMS unit is coming to your ER with a trauma that is significant, what is a good lead time that you would have that EMS unit make the call to you guys, whether it's on the radio or via phone, to let you know what's coming in? What's ideal for you guys?
If it's going to be a patient who is going to be, how you feel is sick before they get to us, or you're having a hard time achieving hemostasis, then as soon as you realize that the patient's coming to our destination, a heads up would be fantastic. And then a lot of times, a reminder or an update, whether you're 10 minutes out or something like that, would oftentimes be really beneficial. And when I say those things, I say it like that would be a luxury. You guys are busy as hell and you do a great job. And so it's more of just a request on if and when possible, it could really help. It makes a big difference. Your guys' assessment and giving us a heads up how many chest tube trays I have out. If I have a central line versus a cordis that's going to be giving a lot of blood products through their femoral vein versus if I'm just going to have the nurses put in two large bore IVs peripherally that'll never get as much fluid in as a cordis would. Do I need to think, your guys' GCS scores on, am I worried more about the airway or am I getting that cordis in, especially in rural medicine where it's one ER provider? I really have to prioritize which one I'm thinking about I'm going to be acting upon first. And so it's very beneficial to get those updates. It even allows us, if y'all say that the patient's getting worse and stuff, it really call in my surgeon earlier and things like that makes a big difference.
Great, thank you. One comment that popped in the chat box is I thought as EMS we are never to remove a tourniquet. Is that still true, or are there instances where we could?
So it varies from, it has to do with local protocol or within the state. And so that's what I would refer to. It's in here when I'm talking about the tourniquet, I'm talking about any sort of setting, or if it's in any location where it may be okay to take off a tourniquet. I would want you all to refer to the latest guidelines for South Dakota and in your area, whether or not you would. A lot of times you will just keep that tourniquet in place.
Okay, thanks for clarifying that.
Yeah.
Anybody else have any questions? Well, doctor, if you could stay on maybe a few more minutes, we are going to go over some scenarios, and you're more than welcome to participate, or if you have to get going, we definitely understand that. I think Michaela is going to bring up a couple of scenarios. We'll go to the top of the hour on that.
Okay, can you see my screen?
Yes.
Perfect.
So here is our first scenario, and I think probably the best way to do it for tonight, since we were talking about splitting off into different chat rooms, but I think for tonight we're just going to kind of run it all together. So I think I'll read this scenario, and then if you want to interject and you want to talk about this on what you would do, maybe we'll just do this kind of from start to finish. This is kind of our hands-on portion when we can't have hands-on. So this is time to interact and kind of talk about what you would do. So first scenario, we have a gunshot wound to the thigh. We're getting into that type of season. We're already in it with some seasons, but as we progress here into November, we're going to get into the deer season where we're going to be seeing high-powered rifles out there. So our scenarios: you're responding to a patient reported to have a gunshot wound who was hunting with a few buddies. BP is 100/60, pulse is 120, respirations are at 26. The information that you get as soon as you get on scene is the patient was shot in a hunting accident. The thigh has both entrance and exit wounds. Pulse sensation and motor function are present distal to the wound. There's approximately 1 liter of external blood loss. Patient is alert and oriented. So I know sometimes we're a little shy to unmute and talk about it, but let's go ahead and what are we going to do first, guys?
How old is the patient?
Dave asked how old the patient is. We're going to say the patient is 27 years old. And Nicole had something. Go ahead, Nicole.
I said apply pressure to the wound.
Apply pressure to the wound. Great. A question that came in on the chat or a comment is shotgun or rifle. We're going to say high-powered rifle, 270 caliber.
Is it bleeding or not?
Yes, it is actively bleeding. What? Nicole applied pressure.
Tourniquet.
I agree. Tourniquet.
Tourniquet. Yep. Okay. Is this going to be a situation where if we're in a relatively rural setting, which it kind of sounds like it would be, what are some things that we can consider?
Well, you got to consider shock and how far you have to get there.
Yep, shock and how far we have to go.
Might want to call the chopper.
Yep. Call chopper. Yep. Anybody else?
It looks like on the chat, control bleeding.
Yep. Control that bleeding. Consider chopper. If you don't have a chopper in your area, consider ALS so we can get, fluids going in this patient. I think we've done a really good job with this one. Good job. Doctor, do you have anything to add on this one, or did we do all right there?
No, that's great.
All right, let's move on to the next one then. Impaled object. We are responding to a trauma patient with bleeding. Vital signs, 110/70 on the BP, pulse is 90, respiration's 24. Lung sounds are diminished on the affected side. So I would say that we have an impaled object in the chest. Patient is not significantly dyspneic. I can't talk to you guys see it. Patients found in a sitting position. And the history of the event is patient was on a ladder hanging Christmas lights and they fell and they were impaled with a wooden stake. So we've got control bleeding, keep warm. Anybody else?
Stabilize the stake.
Stabilize the stake, and Carrie jumped in on stabilize the stake too. So we're all thinking alike. Good job. Anything else you guys would do initially on the scene?
Treat for shock.
Call that in.
Call that in. Very good. Yep.
Keep him in a position of comfort so he can continue breathing.
Position of comfort, continue breathing. With what consideration do you guys think, though? Since he did fall
I'd
from a
consider
height.
adding some oxygen.
Absolutely. High concentration.
Yep, very good. Ask for the med list. Yep. Would we consider spine stabilization depending on this patient's C-spine?
Yes.
Very good. Yep.
Collar.
Yep, collar him. But still remaining in the forefront is if we start collaring and backboarding and start trying to lay this patient down and his breathing does diminish, then we have to get creative, right? We can still stabilize him. We can use our CAD board. We can use a short board. We can still stabilize that spine if sitting is the position that he's breathing better, correct? Everybody agree with me?
Agree.
Great.
Yes.
Yep. And definitely load and go, right? And potentially, again, if this is a rural setting, we would want to consider a air ambulance or ALS if that's our possibilities. Doctor, anything else you would add?
No, that's perfect. I'd be thinking about what am I going to be doing with the patient to stabilize and give early blood products, and I would make sure that my OR is getting ready to go and that the surgeon's been called in as soon as possible.
So let me ask you this question. Since I've been involved in a couple of impalements throughout my career, and most of those that I can remember were all metal objects. Does it really matter if it's metal or wood?
That doesn't make
MI.
nearly as much as the location.
Okay. All right, great. All right, I think we're good with that one. Let's move on to the next one. We are responding to a patient with a stab wound. We have BP of 110/70. Pulse is 90. Respirations are 24. The stab wound to your patient's upper extremity, located quite proximal, is producing some moderate oozing of blood. It is located too high on the arm for a tourniquet and is not severe enough to indicate a tourniquet's application. So how would we handle this one?
Scene safety.
Scene safety, very good. I heard about 3 people say that. That's great. Who are we going to want to definitely have with us? And
Law enforcement.
law enforcement. Yep.
Direct pressure and treat for shock, like we've said for the other scenarios.
Yep. Anything different with this one? Obviously, we've got the moderate oozing. We don't have the arterial sprays. Would we want to get any information as far as maybe what it was that was stabbed in there? It's already been removed. Would we want to know that? Is that important?
Yeah. I'd also want to know if he was on, is there alcohol or drugs involved? Because that could make a difference on how we take law
Very
enforcement
good.
along with us.
Yeah, very good. Very good. Direct pressure popped in the chat box. Doctor, anything on this one, or somebody else have something?
I was just thinking his medications, does he take any aspirin, things like that, that would create more bleeding?
Very good. Very good. Yep, that med list. Yep, very good. Doctor, anything else on this one that you would add?
No, that's good.
All right, awesome. You guys are doing a great job. Let's do, what do we got left, Michaela? One more, two more
It looks like one more.
after this one?
Or nope, this is the last one.
Okay, last one. Here we go. So we're responding to a patient with a stab wound. BP is 90/50. Lung sounds absent on the left side. The patient was stabbed. Actually, I should probably read this information before I start making stuff up. Lung sounds absent on the left side. Pulse rate is 120. We have some bruising to the chest. So we have some bruising to the chest. Our stab wound is
Sorry,
on that left.
that's the wrong scenario. One.
That's okay. We'll just forget about the information. I'll wing it. So we have a okay, so let's change here. Okay, so forget about the stab wound. We fixed the guy prior. We're all good with stab wound. So let's do chest injuries following this fall here. So we've got, you respond to a person who fell while getting out of the truck. The bystander who witnessed the fall called 911 and is no longer there. Not a very good friend. Vital signs BP 130/84, pulse is 80 and irregular. Respirations are 16 and shallow. What are we going to do first, guys? We do have bruising on the chest. Say that again, Sam.
Is he conscious?
He is kind of in and out. He's semi-conscious.
When we do C-spine?
We would definitely do C-spine on this one, right? If it came in as a fall. Everybody in agreement there? Yep. What else would we consider here?
Check him over head to toe.
Yep. Check him over head to toe. Do a complete assessment on him.
Concerns of alcohol consumption.
Since it came in as a fall out of a truck, right? And the other guy's not there anymore. So we're thinking that there's something probably going on, right? So is there alcohol on board? Can we figure that out? Hopefully we've got law enforcement with us. Definitely want to take that into consideration for sure. Drugs, are they on any, is this patient on any type of, illegal drugs? Is there a reason why he fell? Obviously without that witness there, it's going to be more difficult. Anybody else have anything to add?
And vital
makes me
signs aren't
wonder
all
if-
that concerning.
I wonder if,
Sorry.
Go ahead. Yep.
sorry, if his irregular heart rate maybe caused him to fall, actually, if he would have
Yep.
slightly
Could be.
passed out or dizziness or something prior to the fall.
Mm-hmm. Yep, exactly. What's another thing, especially when we don't have any witnesses around, that would be really good to have our law enforcement friends gather for us? Maybe get his wallet, figure out who he is, right?
Right.
Get his ID out, get that stuff available to us. So when we get to the hospital, or even if we do have to call in and, maybe ask about this specific patient, if we call via phone and not put that information over the radio, is can we get a med list on this guy? Can we figure out if it is something medical or if it is something else? Very good point. Look for a bracelet, look for an emergency bracelet on him. Maybe he's got something else going on.
Could they be a diabetic?
Yep. Could they be a diabetic? Do we have that bracelet? Do we have that jewelry on that's telling us that? Doctor, anything else on this one that you would like to see us do?
No, I think that's great. I think that if he's intoxicated and he obviously has some things going on with the irregular heart, that if he's intoxicated or under a substance, we do need to make sure and do a lot of the thinking for him. If I think at one point in the scenario it says he's kind of trying to refuse. Is that right? This gentleman's trying to refuse care.
Yeah, as he's coming out of consciousness, he gets back to alert and oriented, and he's trying to refuse transport. I kind of made some stuff up that probably didn't fit, but
But it's just
you guys all know it all happens.
yeah, he's just how much we gotta just not give in to him refusing when he's clearly not thinking straight. In a week from now, when he's sober, he would regret the decision he's making right now. So we really gotta advocate for him more than he's advocating for himself.
Yep, sober or when he comes out of his potential medical condition that he might be dealing with as well.
Right.
Yeah. All right, guys.
got a
Fantastic. Go ahead.
Question in the chat. Is it winter? It's one of the questions.
Yeah, it's like it was last week, winter. It's cold, it's snowy, it's wet. Yep. All good things to consider. And then how long was he out there? You know, that goes back to the ABCDE exposure. How long was he, out in that cold, laying in that wet snow, wet ground, things like that we have to take into account as well. Very good. All right, guys, we got it done by 8. Dr. Gabriel, do you have anything else to add tonight?
Thank you for allowing me to participate.
And thank you for participating. We always appreciate Sanford getting us speakers, and yeah, it's awesome. So thank you very much for participating, and hopefully you'll want to come back.
Yeah, I'm excited to meet you guys too when you're bringing in patients.
Awesome. Great. I think that Michaela's going to put up a quick poll. There it is. So if you guys want to vote on that before you leave, and Rosa, to answer the question, I'll be in touch with you guys on EMT class. Question in the chat. What number do we use for me? Use 605-216-1677. And once you've taken the evaluation, make sure that you let me know if you need me to sign you up. I did sign up a couple of people that weren't signed up that I noticed were in the group. So if you sign up and it says you're already signed up, I did it for you. And that's all we have for tonight.
Thank you very much.
Yep. Thank you for participating.
Thanks, Kyle.
You bet.
Yep, thank you.
Bet.
I appreciate this. It's wonderful. Thank you.
Yep. You bet. Thanks for participating.
Hey, what district are we in?
We're in District 4.
Okay.
Okay, it looks like everyone's voted. So I'm going to close the Zoom call.
All right. Have a good night, everybody.
Thank you.